Thank you very much. Indeed, I first want to share about patient involvement in concerning multidisciplinary approach using patient decision aids. This is the disclosure for this presentation. So very briefly, what it's about, I give you a very small background about shared decision making. And why we empower patients to take a proactive role in the treatment pathway and the decision on that. Then how you can do it with a shared decision. So we developed one in the Netherlands on prostate, and then we did a trial on validation setting and also using some artificial intelligence on how we could do it. So very briefly, the background. One, could you use shared decision making? So when there is theoretically not a clear preference in the treatment, and when there is more than one option available. However, so
We cannot listen online.
From the diagnosis and 1 and 2 years after the treatment. It's a multi-center, so there were a lot of hospitals who were collaborating on that. There were 57, and they were validated on 8 hospitals, and all the treatments were on that. So the robot laparoscopic prostatectomy, also the external beam, the brachytherapy, and the active surveillance. And here you see some distribution of the urinary incontinence after the first year. So at the top, you see it at the diagnosis. At the middle, it's at the first year, and at the down, it's at the second year. And you see the numbers displayed here. They are a bit small, but you see the green, the yellow, and the red bars representing with least moderate and most severe forms of urinary incontinence problems. And you see that it's after the first year, it's its highest percentage, and then it slightly improve a bit. When you have a closer look on the right one, that is solely after 1 year, and then you see that the severe type of urinary incontinence was most frequent. Yeah, of course, we can say after a prostatectomy, but we saw that urinary incontinence decreased to 65% after diagnosis and 63%, so very smallly after 2 years. And you see the distribution. So it's also most distributed patients were in the prostatectomy group, a few in the active surveillance, and it's brachytherapy here. It's a small group. So when we have a closer look on the urinary incontinence, we see that for the prostatectomy, it's like using a pad after 1 year, it's 1 out of 3. After 2 years, it's 1 out of 4. So it is an issue. And when you see it for the prostatectomy that has no troubles, it's like 40% more or less. But when you have a look for the active other treatments, it's also with active surveillance, you see also trouble. So like nearly 80% used no pad at all, but 20% does. And when you see it after 2 years, it increases. So it is also with an increasing of age, the function is decreasing. And when you see it for the treatment, it's interesting with brachytherapy. Okay, it's a small group, but they got like a better function preservation. And the hypothesis is that the prostate is shrinking a bit so that there is less resistance for the mixture function, so that it has less trouble on that. When we have a closer look on the AI, what is used, there is an 1 year outcome with 11 variables who are detected, and there were some machine learning algorithms used. So there were 3. We got the logistic regression, the random forest, and the support vector machines. Yeah, that's about the AI that we can predict on specified variables, that we can predict the outcome and the urinary incontinence, depending on which treatment you got. So we developed then a nomogram for 1 year prediction on urinary incontinence. And when you have certain classifieds, like for example, if you got urine loss or you got no control and you got a prostatectomy treatment, then you got a number of points. So let's say in this particular case, you got like 250, and then the probability of urinary incontinence in this worst case scenario is like 75%. We also did that for erectile dysfunction. So we see also that the erectile dysfunction is decreasing at diagnosis when we continue 1 year, 2 years after. And the distributions, you see that depending the treatment you got, it's varying. We also made a nomogram on that, and depending on which kind of impact factors that you got, we can also make the same calculation and make a prediction on what the probability is of your erectile dysfunction. And when you see it like here on the treatment schedule, it's prostatectomy got like the worst outcome for erectile dysfunction. When you compare it with external beam, and then with brachytherapy has the lowest impact on the erectile dysfunction. So when we can conclude, there are some limitations also on that prospect database. The incidence of severe form of urinary incontinence is relatively high in this series of patients, so it's 35%. When we also have a closer look, I already showed it, but mostly of the patients got radical prostatectomy or active surveillance. So there should be a need for validation for the external beam and the brachytherapy population. And also it's solely based on the Dutch population. That is also a bias, so it should be external validated with another population. To conclude, shared decision making is a valuable tool in the treatment choice for a patient. And patient decision aid is helpful, so it can be beneficial for the patient. And the prospect models that we constructed is data-driven shared decision making. So but that should be more fine-tuned and validated too. So we say it's like a 2P medicine, so it's personalized and participative and not paternalistic medicine. So thank you for your attention for this presentation. I'd like to continue with a small presentation that I would like to give in the previous setting about remote training for the transperineal procedure. So that was a bit skipped off. I like to give this. It's briefly. Okay. This is about the transperineal procedure. So it's very broadly. About remote training. A very short introduction, and I want to show you the remote training platform with an example and an example movie, and then make some very small conclusions. So transperineal procedures are increasing. We're using it for all kinds of different procedures like biopsies, fiducials, rectal spacers implantation, brachytherapy. But so it's a technical act, and we should teach it very well. And for the urologists, they have traditionally a transrectal point of view. So the mindset is transrectal, and we have to shift this transrectal mindset to a transperineal mindset. So shifting from that mindset, we can use imaging teaching techniques. We can use that by didactic instructions, also with hands-on training, like with a crash training. That's live training based, but it's also beneficial when you can have like a kind of an after work, so that you can take care of what's happening in your own hospital. And that can be beneficial with a remote training set. So the live settings has some limitations. You always have not the view of the patient, so you're always sitting beside. It's also trainers limited, so you have the limitation of your proctors. If you don't have, you can't teach it. And that means that there is a relatively slow adaptation of new techniques. And of course, there are additional limitations of costs, traveling, environmental impact. So that could be beneficial by remote training platform. What do you need? Not that much. You need like a good internet connection, and we developed an extended reality headset so that you got a real live contact with the OR. So you got a camera display on, and it's with projecting the two parts of the image. So you got the ultrasound, that's of the transperineal approach, and you got also the projection of the hands of the surgeon. So you see in real life from where you are what the student has to do. And he can give additional live instructions. So I've got like now a short example about remote training. My student was in Rochester in New York, and I was proctoring in Europe. So I was just sitting in my office, and he was doing a transperineal procedure. So we take like the example of a fiducial, and I teach him a bit about the anatomy and then guide him through the procedure. So I like to share this with you. It's a short movie, so we can have a look. Does it work? I think you should take that other view, of course, yeah.
We're here in New York, in the United States, and we're here in New York, in the United States, and I can see I have the extended reality headset from me that we're going to be using for training. As you explained, I have the camera and the glass speaker optics in my headset. Now I'm going to go ahead and put the headset on, and now I'm going to select my first camera, so you can see the display that I have in front of me. Okay. So next thing you can see that the setup that I have in front of me, I have a Brachytherapy separate setup. I have the Alfaisal Pro. We have a Brachytherapy grid with a prostate and lighting. Of course, I have the EEs with loaded visuals on the left-hand side of the desk. Now, to the left-hand side, you can see I have the Alfaisal unit that imaging feed which is being streamed directly into the remote training platform using this media connection up that's sitting on the desk in front of me. Now, as I go back to the display in front of me, I'm going to select my Alfaisal to enable it so that you can see how I orient it setup. Okay, so now you can see everything that I have in front of me, both the setup of the prostate and the Brachy Stepper Pro, as well as my local Alfaisal feed. And as I scan the Pro left and right and center plane, you can see the ultrasound.
Insert Pro. So now we get here, wait, go back. Here we got the anal rectal valve. So this is always important to implant rectal spaces. That's the area that we have to do. go into the space in your prostate and your anal. So this is the apex of the prostate, and this is the urethra. So you go ahead, go further into the prostate. So you see the complete body. You got the anterior side, and here you got the inferior side of the prostate. We've already the base. Here is the base. Maybe you can see the axial view. And you can check position where you want to go. Yes, this door here, the physical symbol. And now we go back to the apex side, I would say. Here we go to the base, we go further back down. You see good the contours of the prostate, and now you choose the position where we can enter very low prostate. I would say big E3. So here we should go enter the prostate. Yeah. Big E from here. 3. Yes. Should not be that. Can insert needle, yes. We are there. You're 2.5.
Yeah, it looks like about 2.5.
Yes, okay, here it is coming. And that's a good position. So now you switch your plane to cyclical view. So with the probe, you go. Okay. With the probe, you have to turn out to the right. Oh.
Okay. Turn the probe now, right?
Yeah, you can put the probe so yeah, the needle should be at the T line. So here is the T line. Your needle is here. Yes, indeed. Now you see the cyclical view, and you will see your needle in a cyclical view. Yeah, and also your image. Yes, exactly. Okay. Yeah, and now you can pass the needle. Yes. Go further. Yes, like now. Now you can take out the white elastic. Yeah. Yeah. Okay. Now you have to keep your right hand in stick and take out the left hand.
Yeah. I'm gonna draw now, I'll see.
You can advance to the bit. You need, yes, advance a bit, and now you are in position.
Okay.
Where I think you have to switch a bit. Yeah, there's something. Yeah, it's not here. Here.
There it is. So yeah.
There it is. It's yeah.
Okay, that's cool. Okay, so you saw very briefly the principle of the video and of the live demonstration, and it's in fact it can be used for primary settings, so in primary teaching, but it can also be used guiding you through a procedure when you're starting your procedures in your department, and you can have the guidance of an expert or from a proctor from everywhere. And the conclusions of it that I want to make is that you get the eyes of the surgeon, so that remote training is feasible with this technology, and it could be designed for that application. That we can increase the use of adaptation of new techniques, that we can have an elimination of the need to travel for proctors and could speed up, that we can increase also training residents and new colleagues who want to start up with new techniques like the brachytherapy. With the headset, you get the focus on the hands and on the ultrasound, so you get the ideal hand-eye coordination. And like I mentioned, we can eliminate need to travel. So I'd like to thank you for your attention, and I'm happy if there are any questions from both.